Buju, Indinoy Maganadok, Anin, Shayla, Nindujnakash, Makwa Ndodum, Makwam Kong Nindonjaba. Greetings, all my relatives. Hello. I'm Shayla. I'm Bear Clan and a band member of Wikwam Kong First Nation. I'm a research associate at Johns Hopkins Center for Indigenous Health, and I am happy to get us started today. First off, thank you all for joining us for today's webinar, Contingency Management, Key Considerations for Implementation and Policy in Partnership with Indigenous Communities, featuring our presenter, Dr. Kait Hirchak. On behalf of the Johns Hopkins Center for Indigenous Health and the NIH-funded P50 Center of Excellence, also known as CIRCLE, we are excited to have you here today. CIRCLE, which is short for Community-Driven Indigenous Research, Cultural Strengths and Leadership to Advance Equity and Substance Use Outcomes, which is also here in our logo. This focuses on addressing substance use disparities through culturally driven prevention programs and policies developed in collaboration with and guided by Indigenous communities. Our work includes supporting Indigenous-driven research, training, outreach to better understand and address substance use inequities across diverse tribal cultures and contexts. We're growing as a national resource by supporting the development of rising Indigenous scholars, advancing innovative research methods, creating tools and resources, and hosting educational webinars like this one. Today's webinar is part of an ongoing series hosted by the Circle Center of Excellence, and we are truly honored to have you join us for this conversation. At this time, we'd like to invite you to share which lands you are calling from in the chat. If you're unsure or don't have access to the chat, we still invite you to take a moment to reflect or acknowledge the land or the Indigenous peoples of your region in your own way. I am calling in from Pueblos, Tigua, Pero, Dene, Nuchu, and Nade lands, and these are the lands that the Johns Hopkins Albuquerque office occupies. These Indigenous communities have long-standing connections to this land, and their histories and cultures continue to be significant within and around the present-day settler state of New Mexico. And I remain actively committed to supporting these communities. And thank you for those who are sharing in the chat. Okay, a few final notes before we begin, just some quick logistics and housekeeping items. This is a webinar, which means that attendees are automatically placed on mute and cameras are off. If you have any questions, please use the Q&A box or the chat. And we'll have about 15 to 20 minutes at the end of today's presentation for Q&A. So we'll save the questions for the end of our call today. And my colleague, Andrea Medley, will be facilitating the Q&A. And I'm now going to pass it over to her to introduce our speaker for today. Thank you.
Well, Shayla and Songite Law. Good day, everybody. My name is Andrea. Ch'adas Igna is my Haida name. I'm from the Haida Nation, and I'm calling in today from the unceded and occupied Piscataway and Susquehannock territories here in Baltimore. So I have the honor of introducing our speaker today. Dr. Kait Hirchak is a descendant of the Eastern Shoshone Tribe. She's an assistant professor at the Washington State University in the Department of Community and Behavioral Health and a faculty member in the Promoting Research Initiatives in Substance Use and Mental Health, or PRISM Collaborative. For 15 years, she was partnered with tribal communities to enhance health equity and well-being. Dr. Hirchak's research interests and training include health policy, prevention science, and culturally centering and assessing evidence-based interventions for substance use with American Indian and Alaska communities. Dr. Hirchak collaborates on several National Institute of Health grants focused on substance use treatment research with American Indian and Alaska Native communities. So welcome, Dr. Hirchak, and thank you so much for joining us today to share your work. And I'll pass the mic over to you.
Wonderful. Yes. Thank you so much for the introduction and the Circle Center team for bringing us all together. And thank you everyone for joining us today. So as was just mentioned, I'm Kait Hirchak, and I am a descendant of the Eastern Shoshone Tribe, and scads of other European ancestry mixed in, mainly Italian. And I always like to start out with a little bit about my positionality, as well as the WSU land acknowledgement. So my mom and extended family still reside on the Wind River Indian Reservation in Wyoming. And I am calling in from the beautiful lands of the Squaxin. And WSU is a land grant grab institution. And I invite folks to check out the full statement on the WSU website. We have an Office of Tribal Relations that's working really hard to address some of the harms that have been created. And so they're doing great work. So I invite you to check that out if you're interested. I also want to acknowledge our fabulous team. It takes so many people to do this work. And right here, we have a picture of some of those awesome folks standing alongside the Spokane River. And our work that I'll be talking about today, focusing on contingency management, is a real partnership led by Michael McDonald, Michelle Peavy, Sarah Parent, and others listed here. And of course, we could not do this work without our tribal partners due to various data sharing agreements and other considerations around confidentiality. We don't always identify folks that we've partnered with, but so important and integral to this work alongside our funders. And then I have some disclosures here at the bottom. So I wanted to start out by talking a little bit about our partnership story around contingency management and really placing that within the significance and the need for contingency management. And the work that we have partnered around has mainly focused on addressing alcohol use and stimulant use disorder. And whenever we're talking about alcohol use with Native communities, I always think it's super important to address some of the stigma around misconceptions of alcohol use. And so especially that there's variation in alcohol use, especially by tribe and region, and that American Indian, Alaska Native communities actually have some of the highest alcohol abstinence rates, especially compared to non-Hispanic white adults. And then when we're thinking about methamphetamine-involved poisonings and fatal poisonings, we see some of the highest rates among American Indian, Alaska Native adults between the ages of 25 and 54. And then it's also methamphetamine and other stimulants involved in combination with fentanyl is also the highest. So really thinking about how we address these health-related inequities that are due to substance use and higher than the national average. And so one way that we think about this is approaching it from a really tribal or community-based participatory research approach, so very community engaged, thinking about community-driven solutions and how we might center those, and then thinking about culturally appropriate or responsive interventions that are identified by the community that they feel will address the complexities that they face, while always recognizing that communities have the strengths and the answers and the solutions to those complexities, and that we can offer one tool that might benefit both stimulant use and alcohol use, which is contingency management. We feel that is one culturally responsive way. And so contingency management, a lot of folks are becoming more and more familiar with it. The first thing we usually hear when we talk about what is this is the name. So everybody always wants to change the name. And so that's something we usually start out with. So some of the clinical trials that I'll be referencing today was helping our Native ongoing recovery and rewarding recovery. But basically what contingency management is, it's based in operant conditioning, which is basically a theory around learning where positive and negative reinforcement is used to modify behavior. And so With contingency management, we really focus on the positive reinforcement piece of that. And so really shaping behavior through positively reinforcing those behaviors that we want to see. So in this case, stimulant or alcohol use abstinence. And so basically through CM, we encourage behavior change. And this is usually completed through providing a tangible reinforcer, such as a gift card, for in exchange for a negative urine point of care test. And so that's the other thing that's really different about contingency management, is that it deals with both money and urine. And so those are things that people sometimes are a little surprised about. And there are some factors to consider around that, especially policy, and we'll get into some of that a little bit later. But also thinking about really ensuring that the program is the correct amount of time. So programs are usually about 12 weeks in length. And it's a really strength-based approach that celebrates people's recovery, their goals, and is a really fun intervention. And in connection with that, it also has decades of evidence in support of it with many diverse communities. And I will be speaking about the work with Native communities, of course. But we really know that contingency management works for many different substances, and is the only effective intervention for stimulant use disorder because there's currently no FDA approved medications. And so with this work, we really started out with research. And so that's been the exciting part with our team, is starting out with the research and then being able to translate that through training and technical assistance work, especially as SAMHSA has become more supportive of CM and included it within the tribal opioid response grants. And so that's been another factor, as well as our continued research that we have with our community partners addressing stimulant use disorder. So that's some of the high level definitions of contingency management. And then another high level piece that I wanted to quickly go over was a bit about the partnership itself. And so, as I mentioned, I'll be talking about 2 clinical trials primarily. And this included over 514 participant relatives across several communities, both in urban rural areas and Alaska. And we refer to participants as participant relatives to demonstrate the relationality that we have and the kinship across the communities. And we ultimately randomized 272 participant relatives across the 2 clinical trials. And I will show you more data. You may not want to see it. I'll show it to you later. But high view takeaway is that, yay, CM reduced stimulants and also resulted in abstinence from stimulant use, reduction in abstinence in alcohol, and reduction in abstinence in cannabis use. And so, as I mentioned, we've continued this work through our TTA. So that's been really great. And the work started in 2012. And so you all might be familiar with this wonderful activity, the River of Life. And this is a process that is completed within teams, across teams. It's a tool that Dr. Nina Wallerstein has developed, and it really looks at the different phases of the partnership, the community engaged approach. So it's really bi-directional learning, really about supporting the capacity of communities. And so when we started in 2012, you can see that's at the top, hopefully you can see that's at the top of the river there. And when we were starting to think about contingency management, there were meetings that were completed with community partners, and we were thinking about what substances would be of interest to partner around, what interventions might be of interest. And so a menu of interventions were presented that the WSU team had expertise in. And the one that we resoundingly heard would be the most beneficial or of interest was contingency management, and that there would be alignment of that with community values and cultural values. And so we were able to then also address alcohol. This is referencing the Helping Our Native Ongoing Recovery clinical trial. So that one was addressing alcohol primarily. And we were able to develop the proposal. And then we can see as we're coming down the river here that we did have some considerations around capacity for communities to implement CM and areas or thoughtfulness that needed additional attention around organizational fit. And so some partners had to leave, but they stayed on our community advisory board. And so this is just a nice way to kind of highlight a partnership, and one that I would recommend to others who are thinking about this story and their own story and where they're hoping to go with their partnership. And so now we're in the post-study phase, which, as I mentioned, has led to not only training and technical assistance, but also work around additional research funded through NIDA. So that has been really exciting as well. So I wanted to also highlight the ways that we have gone about culturally centering contingency management. And one of the ways that we went about doing that was conducting qualitative interviews and focus groups. And so I wanted to highlight a few of those quotes. So the focus groups for this work were 9 focus groups completed within 3 communities. And we heard about the alignment of contingency management through this idea of the provision of incentives or rewards, and the thought of how you celebrate that, how you encourage that, really thinking about extending it beyond just what incentive or reward would people be interested in, because that's really a core piece of contingency management, is ensuring that the incentive or reward is, elicits that behavior change and that excitement and that response of really motivating people to meet their goals. And so thinking about how to culturally center this work beyond that was around the inclusion of language and cultural stories when appropriate. And so we had some folks that highlighted that within our work. And then we also completed some qualitative interviews and focus groups with 25 18 to 29-year-olds and their family members, as well as providers. And what we heard from them around sort of this positive reinforcement and substance-free activity was thinking about, we have one individual who said, some people feel spiritually connected when they are in that, what we call the circle, which would be the sweat lodge or the Sundance circle or the powwow circle, because a lot of our traditions involve the circle as well, which aligns well with your work with the Circle Center. So that resonates for a lot of folks. And then just reading the other highlighted quote here is that we did everything together. We sat together, we told stories together, we ate together. So just really that piece of social connection and social support as well. And so when we were moving forward with thinking about what that might look like in terms of adapting the intervention, we tried to work with our community advisory board to think about how that might look. And so ultimately, what we ended up including was having elders and community leaders guide not only the intervention, but elders also delivered the intervention, which was really amazing and awesome. And another thing that we love about contingency management is that you can be more creative in who delivers the intervention. And it mainly, I mean, of course, there's skills involved, but it's really somebody who is non-judgmental and encouraging and supportive. And so elders can also, be supportive in a way that others cannot be, and can really encourage people in a way that other folks can't. So it was really great to see them be able to encourage participation. And then really thinking about having positive affirmations within the setting of where contingency management program is being implemented. We had language written on the different materials that we had from Native community partners when and where it was appropriate to share, as well as whenever and wherever it was appropriate to share certain cultural stories. Another important piece was really thinking about, and this was also highlighted in the qualitative work, was thinking about how we celebrate people's journey and their success. And so some of the rewards that we provided around that were like smudging kits, including like sweetgrass and other ceremonial materials, as well as beading kits and ways for folks to really engage in those activities. And so we also had sweats was another example of cultural offerings alongside invitations to other events such as regalia or ribbon making skirt activity workshops. So just really being able to get creative in what is most meaningful to the community and to that participant relative engaging in the program. So another way that we also further culturally centered the work was thinking about mapping on a contingency management visit onto the medicine wheel. And this is a culturally meaningful framework for my community and the other communities that we had partnered with. We have opportunities to continue to think about this and apply frameworks that are meaningful in other areas, since the medicine wheel isn't meaningful everywhere. But really looking at this medicine wheel and how it kind of describes the contingency management visit is that I think a lot of people are surprised to learn that a CM visit is like 10 or 15 minutes. So it's not that long. And folks come in twice a week. And so it's a really great brief opportunity just to connect with folks and support them in wherever they're at in their life. It builds a lot of connection between the person delivering the intervention and the participant relative coming in. And so that's really where we're starting here with thinking about greeting the participant relative and checking in with how their life is going, how things are going. And it's a really nice way to kind of think about the intervention in more of a holistic way, where we're really trying to create that harmony and balance in wellness, and thinking about how we can address the spiritual, emotional, mental, and physical domains of wellness, and sort of the harmony in that related to environmental factors, connection to land, connection to other family. So really highlighting that work as you go. And then once we've started in the East and we're moving down to the South, where you measure, so that's when you go about collecting the point of care urine drug screen, and then moving to reinforce, where if the urine drug screen is negative, it's a celebration, it's a lot of fun, people are excited to receive their gift card or reward. And if it's positive, then it's a check-in, a connection to additional resources, an opportunity to reassess where you're at in a non-judgmental way, and just really supporting folks where they are. And then, of course, like I said, because CM also deals with money, you really need to make sure that you're connecting the incentive and the reward that's provided to the outcome, so to that negative urine screen. And we have different tools to do that, but you really don't want any sort of issue around Medicaid getting mad at the process of you not having recorded those two things together. So really want to stay on top of that. And then always just really thinking about gratitude and being on the journey of a person's recovery with them. And so really highlighting that strength-based approach. So another way that we have thought about sort of culturally centering this work is around the presentation of contingency management. So storytelling being one way that's been really important, and another thing is the importance of visuals, so having those infographics. But we've developed composite stories around different fictionalized participant relatives who have come in, and we've thought about, how do we engage folks? How do we keep them engaged? So that's been one way. And then in terms of looking more to the right of the slide here, this is more to help folks that are actually delivering CM. There's a lot of folks that get nervous around, not being able to provide that reward if the urine test comes back positive, or how to address folks who feel like maybe their test came back incorrect. And so just really having a lot of conversations around this, and a lot of practice helps a lot. And so we've developed some materials around that as well. So the other thing that we were thinking about is that CM is effective. And one of the ways that we have demonstrated that was through our clinical trials. And here we have the Rewarding Recovery study. And this was completed with one rural reservation community, and we ultimately randomized 114 participant relatives. And this is a little bit complicated in terms of some of the design for me anyways. But what you're looking at with these figures is, on the left, we are looking at the percentage of alcohol negative urine samples. And the design of the study was that we had 4 groups. So we had, and these are represented in the different colors. So the red represents the group that received incentives for attendance, so regardless of substance use. And they were the control condition. In the navy blue dots, we had the group that received incentives for alcohol abstinence only. And then in the yellow, we had the group that received contingency management for their primary substance abuse, their primary drug abuse only. And then we had the really fun group that was reinforced for alcohol and drug abstinence. And so on the left, we can see that the group that was reinforced for attendance only were significantly more likely to attend visits. So that makes sense. And then we also see, though, that the 3 CM groups compared to the attendance only group were also more significantly likely to submit alcohol abstinent urine samples compared to the attendance control group. And so that was really exciting that we were seeing this abstinence, and that we were seeing that across the 12-week period here. And then on the right side, we're looking at percentage of drug negative urine samples. And again, we're seeing that the CM for drug abstinence and CM for abstinence from both alcohol and drug group were significantly more likely than the attendance control group to be abstaining from their primary drug. So we were really excited to see that, especially because the impact on stimulant use, the odds ratios were very high with that. So ranging from 4 to 8 times higher stimulant use abstinence compared to the control group. And that's also in alignment with research with other non-native communities, where there's these large effects, and then there's also secondary effects on the substances that were not being reinforced. And so in some of these, we're seeing the secondary impact on alcohol, even though it wasn't being reinforced. And then in our other clinical trial that was specifically addressing alcohol use, we were seeing very large secondary impacts on cannabis use, reduction, and abstinence. So that was really exciting to see. And also really important to note that this work, especially related to alcohol use and contingency management, is the largest clinical trial with Native communities, and then also of CM with rural communities. And so I always think it's really important to highlight that Native communities are providing treatment and care that is positively impacting health outcomes and really leading that work. And I think that that needs to be highlighted and celebrated as much as possible. So I'm always excited to be able to share those results. I also wanted to talk about some of the policy factors impacting the implementation of contingency management generally. And so when we have been working towards implementing this with American Indian Alaska Native communities, we have run into some obstacles related to Health and Human Services Office of Inspector General and some of the requirements that they have set around the use of incentives in healthcare. And so contingency management does not have its own safe harbor guidance around the use of this evidence-based project. And while there has been work around getting this addressed, it's still, there's no safe harbor specifically for CM. So that's something that we ran into as a consideration. And so it leads to more considerations related to Medicaid and how folks might be able to implement this in a way that follows some of the incentive-based safe harbors. And then another restriction that we've ran into is around Health and Human Services having a $75 limit on the amount of incentives per participant relative per year. And so the research really shows that effective dose of contingency management is at least $350 per participant relative for the 12-week period. And so a lot of work has been going into getting this restriction lifted. And we have heard that maybe fingers crossed this week, it might be addressed, and it's on the desk of Biden right now, and so President Biden. So we're really hoping that that we'll be able to have some good news, and then if the $75 limit on incentives is lifted, then different federal dollars might be able, you might be able to use those for contingency management. But currently, you need to find other ways to braid funding in order to address the $75. And so one way that folks have thought about that is through using some of the opioid settlement funds for their program. There's been a lot of innovative ways that different folks have addressed this issue with their own tribal enterprise or other mechanisms. So you can get creative, but we're still hoping that the $75 limit will be lifted, and that there will be a safe harbor that really recognizes that contingency management is an evidence-based program with a lot of evidence to support its use, especially with stimulant use disorder. The other thing that we think makes this really important too is that Native folks are the racial and ethnic group that's most covered under Medicaid. And so those restrictions really impact where they receive services. So that's another way that it is especially impactful for Native communities. And then the other piece is really thinking about being able to access contingency management as a Medicaid benefit. And so this has been achieved through some Medicaid waivers that have been submitted through different states. So for an example, California has a really successful CM pilot project that allows CM to be delivered as a Medicaid benefit. But there's also been some challenges around states really integrating Native communities within their waiver applications. And so it has led to some challenges and barriers that definitely need attention. But that is another way that communities can obtain CM. So another state that has an approved waiver is Washington State. So folks here in Washington can receive CM as a Medicaid benefit. And then, of course, there's others. So it is becoming a little bit more available, but certainly that seems to be one of the clear pathways to CM. So lots to consider, and always happy to chat more with folks who are interested. Can definitely contact me about any of this. So I think what I was hoping to kind of talk about in terms of the big picture takeaways is that Indigenous communities have the cultural strengths and knowledge to heal from settler colonialism. And I think that contingency management is just one approach that can really help to address stimulant use disorder, and it can be, continued to be adapted and culturally centered. And so it does have some flexibility in how it's implemented, which I think is super important. And then the other piece is really thinking about how much this work is also focused on enhancing capacity. So whether that be workforce capacity or research capacity, being able to really support the next sort of generation of researchers and providers is so important. And one thing that has been really great with the honor project and the rewarding recovery projects that we have been a part of. And then just thinking about these additional supportive tools that are needed. So we need more supports around, the training and implementation of effective CM. So there are some aspects to this program that you really, really do need to maintain fidelity around. And so making sure that you have the ability to do that, that you have the resources and training to do that, and then the sort of the policy considerations that I mentioned earlier. So I think that was everything I was hoping to cover. So I'll turn it over to Andrea because I think you were going to chat about some questions. But thank you everybody for attending and for your attention.
Thank you so much, Dr. Hirchak. I know I have some questions, and it looks like we're getting some questions in the chat. So we have a good old 14-minute period of time to get to some of these questions, as many as we can. I'll save mine for a little bit to give other folks a chance to ask. So please get them in the chat before I use my facilitator privileges to ask. You get some love in the chat here. So thank you, everyone. Alrighty. So all these questions look great so far. So
Yay.
hey. So anonymous attendee is curious to know, this is a two-part question. One, how did you analyze all of the qualitative data you collected? And two, you spoke about this a little bit in your presentation around funding for contingency management. I see why people want to change it.
Yes.
What does sustainability for these types of programs look like? CM, we'll call it, seems grounded in monetary incentives. How can this approach be sustained while also fighting the capitalist system we exist in?
That is a very good question. So starting with the first part of the question, we usually have 2 to 3 research team members independently code all of the transcripts, and then we develop a code book, and then after we go through an iterative process around the codes, we present the information to our community advisory board, the different codes and what we're seeing, and we get more feedback around that. And then we code all of the transcripts and then develop the different themes, and again, chat with our community advisory board and participant relatives around what we're finding. And then we do more of a some of our work, we do medicine wheel framework of how we want to apply the data to the adaptation of the intervention itself. Other times it's more guided by the community advisory board or elders. I've worked with folks who've used other approaches or frameworks to that work as well. But that's sort of the initial way. And then, yeah, we just then try to apply the information to the implementation of the development and the implementation of the intervention itself. So hopefully that answers the first question. And then for the second question, so that one was more around funding. And I think that what we've also found is, being creative can look a lot of different ways. And I don't know exactly, it kind of depends on what state you're in. But some folks have been able to use some of their unrestricted funding from Medicaid to enhance some of their contingency management programs. So that's been one way. As I mentioned, the opioid settlement funds has been another. Gaming and other enterprises have been a way to fund contingency management. We've had conversations with folks who have been able or have a different sort of approach to their healthcare system, where sometimes their per capita payments are used to pay for healthcare. And so it can be applied in that way as another way to fund your program. But you certainly, and then of course, SAMHSA, but then again, you'll be restricted by that $75. So really, grant writing probably has been the most consistent way. And then thinking about how sustainability is so important. I think that that's probably one of the first questions we get nowadays, because I just think that people have been so sort of disappointed with projects being in existence and then going away after the grant funding. And so we have been really more proactive in thinking about how to sustain these projects. And so those conversations now tend to happen more on the front end of the project than probably they did in the past. And so folks are really sensitive to that. I'm trying to think. So then another thing too is around incentives. They can be rewards that are, the focus of CM is that the incentives are immediate, they're tangible, but you can, as I highlighted, couple that with more experiential rewards. And so I think that's one way that, as you mentioned, to really think about how to address capitalism within this context, because I know folks sometimes are concerned about sort of the monetary aspect of this and what that looks like for Native communities. But I think that because the intervention is so focused on being supportive and repairing sort of family relationships and engaging in cultural activities when and where appropriate, that it doesn't necessarily have to be so restricted by basically the money, but that is definitely, obviously, an important piece. So funding your staff time as well, and the other supplies that go into this. So great question.
So many good questions. And however, your response there, you kind of wrapped up in a few other questions into that answer. So the next question came from the chat, and it's around the urine screening, and kind of can you speak more to how you approach urine screening from a culturally centered approach?
Yes. So some people really can't hang with urine, but like I mentioned, it is an integral piece of the work. And then it also can have some baggage related to, justice involvement or some punitive approaches that may have occurred with other treatment experiences. And so we would just really focus on it being a data point in a person's story. And so it's really not about being punitive or catching somebody and shaming them. It really is about supporting a participant relative's goals and helping them with that. Even if it is just cutting down stimulant use and not complete abstinence, because that's another hesitation that sometimes people have is, is there an over focus on abstinence with this? But it really can lead to decreases in substance use as well. And the history of CM is really centered in harm reduction. So that's another piece that sometimes gets lost. But it really is important to have these conversations with leadership, with folks in the organization, with the broader community. But ultimately, we found that people really, really enjoy, the people that like CM like it. And so you do have to think about the use of urine analysis and all of that. But so yeah, I just recommend sort of having those conversations early on and thinking about your own program, sort of treatment philosophy. And it can take some work adjusting that if point of care tests have been used in a more punitive fashion previously.
Absolutely. I really appreciate you bringing that in, because that's kind of where my mind was going as well, around, looking at people's goals. And I know a lot of the study you shared is around people whose goal was primarily abstinence, but I appreciate that people can have, different goals, and reduction can also be part of that. So that's great. And we have a few more questions in just a few more minutes, and I want to leave 1 to 2 minutes at the very end for our very special and important evaluation for this good work. We appreciate all the comments. So I'm gonna just ask, I think we have time for a couple more. So back to the study, someone is asking, were any of the advisory board members people with lived experience of substance use, e.g. current or past users of alcohol and or drugs?
I'm trying to think back to one of our cabs. I believe the answer is yes, definitely, for one of them. And we definitely really encourage involving folks with lived and living experience, so that we have representation of folks with lived and living experience on a few of our community advisory boards, but I can't say all of them, and that's really integral. So definitely.
Awesome. So I'll kind of combine these next 2 questions. They're more about outcomes of your study. So can you talk a little bit more about the amount of loss to follow-up you experienced during the 12 weeks? How many people dropped out or stopped coming? How did that differ by intervention group? And then how many people sustained, do you know how many people sustained abstinence beyond the 12 weeks? Understanding that can be a difficult question to answer.
Yes. Okay. Sorry. We're at the 2-minute mark for you too. And I ramble, as you've noticed. I don't know if I can get to that question, but please reach out to me for sure. We usually see about up to a year of sustained abstinence. But with the clinical trials with Native communities specifically, I don't think we saw that. So that is definitely something that research has shown. You might want to continue with some maintenance approaches. And the other part of the question was related to, I may have missed the first part and just answered the second. But yes, please feel free to reach out to me. Happy to chat, email, meet, whatever. If you're in this greater Seattle area, go for coffee. I'm available.
Yay, we'll make sure to, Shayla, can you please share Dr. Hirchak's email in the chat and then the evaluation link? And then, a last kind of parting question, do you have any resources on contingency management specifically for Indigenous communities that you can share? And
yes, definitely.
If you share those out with us, we can include it in our follow-up package that we send out to folks. So this is great. Oh, Shayla, I think you DM me the link. She's going to share the link out with everyone. Just want to express our deep gratitude for sharing your work here with us today. I know lots of comments, lots of love, lots of questions. We want to hear more. This is a really exciting and tangible tool to hear about and learn about and think about in our own communities and our work. So thank you so much, Dr. Hirchak.
Yes, thank you and everyone who attended. It's been really awesome.